Does anybody have any questions regarding this first, about uncertainty? You can also think about it, and we will take a short break, get some more coffee and water, and then what?
Why this illustration? It's showing me coming home to Norway, and this is my office desk. And of course, there's much I don't know what it is, and it's stressing me. And then what I do is I don't work with it, but I sort it. Some things can be thrown away directly, and some things are good to know they are lying there. So maybe the next day I start, but I feel already much better after sorting this. This is a metaphor for this process.
Okay, we will take a short break.
5 minutes too.
Okay, is everyone ready? Then I will start. So in this next session, I'm going to introduce you to like a basic course in shared decision making within the Ready for Shared Decision Making framework. And first, I would like to take a step back and look at communication as a map. Because we can look at communication as a map, actually. We have different kinds of communications. And if we think about this a little bit more, we have different kind of topics. We have anamnesis, we have follow-up with our patients, we have diagnostics, it's a way of communicating. We have breaking bad news, so telling the patients about bad news. And we also have treatment planning. And of course, we also have decision making. So within health, we have different ways of communicating, and decision making is one path. So we can see this pink path, this could be the decision making path. And here we have shared decision making. And behind this shared decision making process, there are some elements, essential elements to do, to structure the communication, so that the patient actually can be involved. And we use these criteria, we call them 6 steps to shared decision making. Okay, so this is the focus of this next session. I hope you, after the session, will understand the background and purpose of shared decision making, know a little bit more, identify when shared decision making is relevant. Also describe the clinician's role in shared decision making and the need for decision support, and also look at this, know a little bit more about these 6 steps, and to support the patient in decision making. So first, I'm going to show you a short video, which we have translated from our Danish colleagues, and it's made available in English. And this is a video for patients to understand shared decision making, and giving them a voice, and knowing them that, let them know that they are, and if they want to, they can be included in decisions. So I hope the technique works. Let's see. Yes, here it is. Okay.
Shared decision making. Who are you, really? What makes you different from everyone else? Some things are obvious to everyone around you, but others only become clear when you talk about them. Many achievements and experiences throughout your life have shaped you into the person you are. No 2 lives are the same. When dining in a restaurant, you choose from the options on the menu depending on what you would like, how hungry you are, and what you know you don't like. You do this because you are an expert at being you. This is also the same when, for example, you go to the hospital. The healthcare professional is an expert in treatments and diagnoses, but they know nothing about you. Not yet, anyway. Based on the knowledge you have about yourself and the expert knowledge of the healthcare professional, you can work together to identify the best choice for you. It's not a matter of you standing alone with responsibility for the decision. Using your knowledge of who you are, the healthcare professional can better support you in making the right decisions, regarding your treatment, for example. Remember, it's you who will have to live with the decision, so it's important that you carefully consider what it will mean for you. You may even want your close family and friends to help you. We call this shared decision-making. You're not being difficult because of who you are, or when you express your wishes or demands and ask questions about your treatment, for example. Sometimes you might find it difficult to decide what really matters to you and what's important. The healthcare professional can help you in considering these matters. The healthcare professional is there to help you, and you are there to help the healthcare professional to learn more about you. Together, you can help one another to take the very best care of you.
Okay, so this is now there's probably coming a lot of YouTube videos that I want to avoid. This is the way shared decision making is presented to our population. This video lies on the national platform, so patients can look at the video there, and we are also promoting it very much to our patients. Okay, so shared decision making has a background in evidence-based practice, evidence-based medicine. And the way healthcare professionals and patients are making decisions is still evolving. And the major milestone was when we actually got this concept of evidence-based medicine. And it said that we should make the individual decision based on scientific evidence, clinical expertise, and of course, patients' values and preferences. This is important. However, we also needed to apply this evidence in practice. We also needed the individual needs assessed and to adapt to the individual needs of the patient. And thereby, shared decision making is actually structured as the method to do exactly that. So we can say that shared decision making is an operationalization, how to practice evidence-based medicine. And the goal of shared decision making, and also evidence-based medicine, is to make informed decisions. So an informed decision can be made by a person, by you, if we know all options, we understand the consequences of the different options, and they are in accordance with our preferences. So these three are the criteria for an informed choice, informed decision. And I will I say it again, that the goal of shared decision making is that the patients are able to make informed decisions, or we make informed decisions together. So what is shared decision making? It's about making decisions. We use the best available evidence when we present all the available and justifiable options and make the individual decisions with the patient. And this happens while the clinician contributes with his knowledge, medical knowledge, and the patient contributes with values and preferences. However, this is not quite enough, because we have to acknowledge, and it's an important concept within shared decision making, that we have to acknowledge that we are not the only ones sitting on the information monopoly, on the knowledge, but our patients also have important knowledge, experience from their lives, and this is totally essential when we make decisions. So we have to acknowledge that the patient can also contribute, and the patient can understand the medical information, but it's up to us as healthcare professionals to provide the information in a way so the patient actually can understand and apply and make decisions with us based on this information. And there we also touch into the concept of health literacy that we have to adapt to individual patients. So this is the concept of shared decision making. In Norway, it is actually also incorporated in our law and the patient's law. And there it says that patients should be allowed to take part in decisions about treating between different available and justifiable options. So regarding treatment, follow-up, and so on. And also on the healthcare professional side, it's also in our act, in our law, that we should, in the ethical guidelines also, that we should provide the patient with the necessary information to be able to make informed decisions. So now I would like you to discuss again a little bit with your neighbor. So for which problem is shared decision making appropriate where you work? Or if you're not working clinical anymore, you're only working with research, then think about some problems, medical problems, health problems, where shared decision making is appropriate approach. Just sum up 2 minutes. Okay, I think I already will stop you here. So this was just to get briefly mentioning some medical problems where shared decision making is relevant. But remember what kind of decisions you were talking about, because you're going to use them later. Okay? Are you still following? I know that you would like to discuss further, and you will be able to do that later. Okay? Okay, let's continue. So remember the problem you're talking about, and you will use this later in the role play exercise. Okay, so I told you that this was included in the law. The next thing I want to talk to you about is that there has been and is some confusion about what is the difference between user involvement and shared decision making. So this was actually a big problem several years ago when we did this kind of training. A lot of our students and also healthcare professionals said that, oh, shared decision making, that's the same as user involvement. So that's why we had to clarify with this slide to make it more explicit. So user involvement in healthcare can happen on many different levels. And it can happen in many different ways. So I know that there are many researchers here. In research, we have user representatives from patient organization, for example, in research projects. That's one kind of user involvement. Policy making, we also have user involvement. On the organizational level in Norway, in all our hospitals, we have user committees, a user board, and they help the leaders in our regions to make decisions and help and to to talk the patient's voice, what's important for the patient. And then, of course, we have the direct care, the individual level, and there we also have different kinds of user involvement. So as you can see here, if we go longer to the right, the patient or the user gets more autonomous. So, for example, if we let a patient of ours express their preferences, oh, for me, it's so important to be home with my family. I really don't want to be in the hospital. Or I really don't want a medication, so I get even more headache, because that's so important for me, because I hate having a headache. That's one way of involving users, that we let them express their preferences. However, it's not shared decision-making yet. So shared decision-making is in the right corner where the patient or the user can be autonomous and make informed decisions based on the criteria I showed you earlier. So in that way, we can say that shared decision-making is active user involvement at the individual level in healthcare in personal decisions. And user involvement in general is a lot more. But shared decision-making we have in this corner. Okay. And in Norway, we have one definition for shared decision-making. And as many of you know, internationally, we have a lot of different definitions for shared decision-making. And there's a lot of different meanings behind the definitions you actually choose to implement. So in Norway, in 2014, we agreed to make one definition, and this definition is in our National Health and Hospital Plan. It's a white paper. So it says, shared decision-making, the patient and the healthcare professionals shall collaborate to make decisions about diagnosis, treatment, and follow-up, and it should happen in the way and to the extent the patient desires. Because I think all of you who are clinicians have many times experienced that patients say, oh, but I don't want to participate. I want you to make the decision. Right? I see some of you are nodding. And that's also, of course, okay. But everybody should be invited to participate and get the information to be able to make an informed decision. Further on, it says that the patient should be supported in evaluating the options based on the best available evidence and of benefits and harms, and also in exploring their values and preferences. And this is a core part of shared decision-making. What are the values and preferences of our patients? Yeah, so this is our Norwegian definition. So now maybe some of you who are not so familiar with shared decision-making are thinking, but what are the expected outcomes if we do shared decision-making compared to making decisions on behalf of the patient? So we usually categorize them in 4 different categories. The first one is the quality of the information. So we can measure that if we include patients in the decisions, we can measure that there is increased involvement. And that is one outcome. Also, the quality of the decision making and the decision, we see that it leads to informed choices. We can measure that. There are measures for doing that. It increases knowledge, so a patient are getting more knowledge about the different options. And their choices also align more with their own preferences. The third one is living with the decision. And we can see that patients have less regret about the decisions they're making if they're involved, and they also get more realistic expectations. So if I do this operation, when can I get back to work? Is it in 3 weeks, or do I have to be in rehabilitation for 3 months? Like, to get more realistic expectations of the different options. And then we have the last regarding health outcomes. And there we have some studies showing improved quality of life, better adherence. And at least in Norway, that is a problem, especially within psychiatric treatments, that patients do not follow up the decisions, not follow up the treatment as planned. And also we have some studies showing that patients tend to use more conservative treatments if they're involved in the decision. Okay, now I would like you to look at this, because you have, as we mentioned earlier, you have received those barrier cards, and you don't have to look at them. I just look here, don't look at yours. So we have a lot of different barrier cards. With barriers, we have collected through research and through experience doing training for clinicians over many years. And on the other side, we have the answer. So this is one that when I train clinicians, this often comes up, that the clinicians say to me, but I already do this. I involve my patients. So another way to say this is, I already communicate well with my patients, or I listen to my patients' preferences, or my patients are satisfied. But being satisfied is not the same thing as have been involved in the decision of making an informed choice. So, are we already doing this? Yes, of course. Many of you and many of our clinicians are doing this. And but we see that there is an increasing part of patients that want to be even more active participating in the decisions. And this is going upwards. And on average, actually, 28% compliance with shared decision-making standards internationally. This is based on a very recent systematic review. And for 10 years ago, this number was 25%, and now it's 28%. So it's going very slowly, but something is happening. Okay. And we also have some similar numbers in Norway from recent studies we have conducted. And the short answer to this is, yes, often only minor structural changes are needed for the quality to improve. And we have had an observer rating now, the last 3 days, observing a lot of videos, a group here, and they have seen this, that often maybe you are presenting like you're not having a structure throughout the conversation, so the patient is not able to follow you. Or maybe you talk about the benefits of a treatment when you already made the decision. So these kind of structural changes I'm talking about. Okay. So one of the core of shared decision making is information delivery. What information does the patient need to make an informed decision? And how should the information be presented? So when we first talk about what information must be provided when choosing treatment decision, and this is regarding treatment and not diagnosis, because there are some additional elements coming in. So what can the patient expect if he chooses to do nothing? Because that's almost often, like almost always, also an option, right? Yes. So what can the patient expect? What are the risks associated with the diagnosis? And what will the natural course of this condition be? This is the kind of information the patient must be presented. Then we must present the probability of positive consequences of each option. And by that I mean reduced risk of a disease or greater likelihood of survival or fewer symptoms. That are the positive consequences, to give some examples. And then also the negative consequences of each option. So possible complications, side effects, or harms a potential measure can cause. So this is only like telling you a little bit about what the patient should know. And when we talk about this, I want to say a little bit more about risk communication. Because Jürgen mentioned this earlier when he talked about uncertainty, and risk communication, how we present the information, is very important. So I'm just going to give you some recommendations based on a lot of studies about risk communication. The first one is that in general, use numerical risk format versus verbal terms only when you communicate risk. So I have watched hundreds of videos where clinicians do make decisions with patients, and a lot we hear there it's rare to have a side effect, or there's a moderate, or it doesn't happen so often, or few, like verbal terms like this. And that's very subjective how we interpret this. So I would like to ask you, how do you interpret rare? Who thinks 2%? Who thinks 9%? Somebody says 17? No? Okay, so on average, patients believe that rare is 9%. So that's something we need to think about when we use verbal terms like this. So that's why the recommendation is, if we have numbers, then use numbers instead of verbal terms only. Okay, the next one is using only using framing, like loss and gain framing to support informed choice. So effects can be framed like positively, how many will survive, that's gain framing, or negatively, how many will die. And using only one of these can distort the risk perception. So it's supposed to include both. It's best to include both, so patient actually can understand this. For example, explain the benefits of a treatment in a positive framing makes benefits seem bigger for the patient. So that's important to the gain-loss framing. Okay, and the third one is how the information should be presented is to use visual displays. This is called an icon array. It's also called a pictogram. There are a lot of different names actually for this kind of diagram. That in itself is very disturbing. So if you're doing research within this, then we have to be more precise on what we call these types of diagrams. But we know that these are clearly display how many out of how many for patients, and they're very likely to understand this kind of numerical information if we present diagrams like this. So, and it will improve recall and comprehension, and also especially for low numeracy group, also patient with low numeracy, low health literacy. And they're, of course, very effective for absolute risk communication. So this is one example on one diagram. There are a lot of different diagrams evaluated. Okay, and the last one is to use absolute risk, because probabilities should be presented using absolute risk versus relative risks. And I'm going to show you one example. So here, in healthcare, it's not about reduced prices. If you go to the shop, we're looking for reduced prices, right? It's about reduced risk. So imagine that you're deciding on a cancer screening. So which one looks better to you? I think most people, maybe not you, because you're researchers and clinicians, but most people would think that this test reduces your risk of dying of cancer by 25%. Oh, I will choose this test. It looks very good. So, and what is the information behind this? It's the information Jürgen presented earlier. So the key point, as Jürgen said, both are technically correct, but they create very different impressions for the patient. And often newspapers in Norway, maybe it's like this in Korea as well, use relative risks. And that's very confusing for the population. Another type of diagram is this. I'm not going to go in detail to this, but this diagram shows the benefits of a treatment and shows clearly that there are only 9 out of 100 patients who have a benefit of a treatment. So this is another kind of diagram and very good evaluated. Okay, are you still following me? So now we have been talking about a little bit about information, what is going to be provided, how we should present it. And now we're going to look more into these 6 steps of shared decision making. So these 6 steps, it's not something new. A lot of you and a lot of healthcare professionals already do like this type of structure. But as I said, there's always room for improvement, especially on how you present and when you present information. So these are chronologically. And then we have these 2 additional quality criteria. So I will now go a little bit more through this. So the first one is to adapt information and form of communication. And by that I mean that if we see that a patient doesn't understand, maybe we should get in a relative, an interpreter. Maybe we have to change our communication approach and to make a drawing or to get a figure and explain how something works. So this kind of tailoring information to the patient. The other one is checked mutual understanding. And I think that we as healthcare professionals are very good at asking, did you understand? So we are checking if the patient understood. So that's one thing, but we have also to check if we have understood the patient's point of view. So it's a two-way perspective here. So when we talk about ensuring mutual understanding, there is a method called teach-back. Is there actually a Korean name for this? I know some of you know the teach-back method. Huh? You use teach-back, yeah. Yeah, we also use the teach-back as in the English way in Norway. It's difficult to translate, right? Yeah. So this is just a very simple but very effective method to let the patient tell in your own words, what have you understood? And then you can clarify misunderstandings and strengthen the patient's involvement. And it's not supposed to be a quiz. Sometimes it sounds like a quiz, like a test, but you should try to avoid that. Okay, so the first step in these 6 steps is to define the problem. Explain the reason. Why are we making a decision? And why must it happen today? Explain the possible and realistic goals that might be pursued to a potential treatment or measure, and also describe how the choice can affect the patient's life. So this doesn't have to take long, but the patient has to understand that there is a choice and why it should happen now, and be like a choice awareness. I'm now going to show you some small clips of consultations from actually Korean videos. So I don't understand what they're saying, but I have the text in English. Okay, so now we're going to see a clinician doing this first step.
안녕하셨습니까? 네, 잘 지내셨는지요?
예.
뭐 정말 불편한 건 없으셨고요.
예.
지난번 진료 때
네.
콩팥 기능이 뭐 원래 조금 안 좋았지만
예.
조금 더 안 좋아져서 추석 이 준비가
예.
필요한 상황인 거를 설명을 드렸습니다.
네네.
지난번에 안내 책자랑 동영상 전달받은 것도 보고 오셨죠?
네, 고맙습니다.
이번 검사 결과도
예.
지난번보다 큰 차이는 없으세요. 그래서
네.
콩팥 기능 타고 체열관 점수가
네.
100점 만점에
네.
한 10점 정도 나옵니다. 지난번에도
네.
지난번이랑 크게 차이는 없고 뚜렷하게 좋아지거나 그런 소견은 없습니다. 그래서 지난번과 말씀드렸던 거랑 동일하게
네.
더 늦추지 말고 향후에 신대치료, 투석 치료를 어떻게 할 건지를 좀 이제 정해야 될 단계세요. 투석을 미루다 보면은 나중에 뭐 요독증이라든지 콩팥병 합병증들이 생겨서 위험한 상황이 생길 수도 있고, 그것 때문에 응급실에 오게 되거나 중환자실에 갈 수 있는 상황이 오게 됩니다.
Did you hear? Okay. So was it clear to you that there was a decision that had to be made? Okay. So this is the first step, right? Very good. So the next step is what we call the key message. And in this key message, the patient should get an invitation to participate and also get a reason for why it is important to participate in the decision. So you can do this in many different ways, and we have seen a lot of different ways to do it. But the essence is to tell that from my personal perspectives, I do not know what the right choice is for you. And this is why we are going to go through this, and we will make a decision together. So again, I'm showing you a video, this time from another medical domain. It's about dentists. So I hope this sound, but did you hear behind in the last row, did you hear what they were saying? In the last video, did you hear? Okay, good.
그런데 오늘 환자분이랑 조금 더 많이 얘기를 필요한 이유가 뭐냐면 이 치아들은 여러 가지 선택을 할 수가 있을 것 같아요. 그러니까 우리가 모든 경우에 그냥 정답이 있어서 하나의 답으로만 무조건 가고 그게 다 해결이 되고 그러면 좋은데 우리가 항상 보는 것인가 제가 치료를 받거나 하면 모든 게 성공하진 않아요. 그리고 혹시 성공한다 하더라도 약간의 불편감이 남는 정도로 해결이 되는 경우들도 많습니다. 그런 것들을 이해하고 나서 우리가 뭔가 결정을 해야 되거든요. 이 환자분 같은 경우는 이런 지금 현재 상태에서는
Okay. So did you think he provided a good explanation and an invitation? Yes? Okay, so this is what we call the key message. And what we also experience is that when this is done in a good way, the patient goes from thinking, oh, such a nice doctor or nice nurse and giving me so much good information and sitting there passive to understanding, oh, you said that I have to think about this because I'm going to experience the consequences. So then they start saying they're listening with other types of ears because they know that they should be active involved. So if this is done in a good way, then sometimes the whole consultation actually changes. And we see that the other steps follow more automatically. Because if you have invited the patient, then it's also clear that, of course, you should present the options in a balanced way. Okay, and that leads us over to the next step, and that is presenting the different options. So here, we within our quality criteria, we say that first you should make a structure. So say that here today we have to choose between these 3 options as one example. And then you go in depth and tell about the different possible benefits and harms of each option and give more information. And of course, also, if we have numbers, present the absolute numbers, if we have them available, and also refer to sources. So like in our national guideline, it says that or in my experience as a clinician in this hospital for 10 years. So then we define the sources of the information. And also, of course, the uncertainty. So as presented earlier, we don't always know. So we should also present the uncertainty information. I cannot tell you how long this treatment will have an effect. Okay, we are going to show another video. This is another medical domain. And they're doing this structure part.
그러는 단계여가지고 지금 한 15% 정도가 됐으니까 이때는 이제 저희가 투석은 크게 3가지가 있어요. 뭐 신장이식도 투석 중에 하나니까는. 그래서 신장이식을 빼면은 혈액 투석하고 복막 투석이 제일 흔한데요. 지금 같은 경우에는 저희가 하는 거죠. 그냥 환자분 같은 경우에 이제 복막 투석을.
Okay, so we couldn't show you. So the next thing here is to go in depth and tell about the different dialysis, right? So this is just to show that he made a very good structure in the beginning and then go into more detail. So we are showing one video more, and this is about ear infection. This is the same step 3, and here a clinician is telling more about the options.
Miss Evelyn seems to have acute otitis media in her left ear.
I thought so. So she'll have to take some antibiotics.
That might not be necessary. In fact, we have 2 options here. Either she takes antibiotics right away, or you wait and see what happens over the next few days. Let me explain. You see here, you have 2 options. Either Evelyn takes the antibiotics, shown in this picture on the right, or she doesn't, shown in this picture on the left. If 100 children like Evelyn don't take antibiotics, 70 of them will feel better within 2 or 3 days, and 30 of them will have an earache for a little longer. If 100 children like Evelyn do take antibiotics, 80 will feel better within 2 or 3 days. You see, only 10 of them will feel better any sooner than if they didn't take them. The other 20 won't get better any sooner. In the next picture, if we look at the same 100 children who take antibiotics, 5 of them will have side effects after taking the antibiotics, such as stomach aches or diarrhea. Of course, I can't tell you if Evelyn is one of the 10 green people who will benefit from the antibiotic or one of the 5 red people who will have side effects. She could also be one of the 80 green people who take the antibiotics for nothing. They'll get better soon anyway. Do you see what I mean?
Yes, the little faces I see. So there is not much chance that.
So this is little bit more explanation. And regarding this example here with antibiotics, I don't know how it's actually in Korea, because this is one of the few topics within health we have not discussed during our dinners. But in Norway, we are trying to reduce the use of antibiotics. It's probably the same here. So then this kind of information is very, very important, because maybe the mother don't want to use antibiotics because the difference is not big, right? So then they maybe use more conservative treatments. Okay. So, and this is also a good point when we get a lot of information in this step to use this teach-back techniques. So then we could say that I want to make sure that I have explained myself in a way so that you understand. So would you please repeat the 2 treatments we have discussed? And then the patient can repeat, and I can clarify any misunderstandings if the patient has misunderstood something. So now we are going to, because the ones we have watched earlier were physicians, and now we are going to, because this is of course also relevant for nurses, and this is a nurse doing this teach-back technique.
Fibrillation is, we've talked about the increased risk of stroke and increased risk of bleeding, and we've talked about some of the treatment options. Can I just ask what your understanding of that is?
It's a lot to take in.
Did you understand? I mean, I understood. I mean, you know that Jim has sort of memory problems and difficulties with some things.
I don't want to have a stroke.
No, of course not. No. I mean, I understood. Yeah, that there are various things, blood thinners that you could take. Is that correct?
That is, yeah. And from the conversation that we've had so far, do you have any thoughts about what type of medication, if any?
And now she's already going into the next phase. Do you have any thoughts, worries about this? And this is the deliberation phase. And so here we should explore, discuss patients' concerns, preferences related to the problem and the different options. So I do not have a video for this exactly step because it's always a little longer, usually. But you can imagine, right? They discuss what are the benefits and how important is this for you? Or what do you want to avoid? Exploring what is important for the patient. And then we have the final, the 5th step, and that is the decision. And maybe you think now, oh, that is clear, of course, the decision. But actually, it's very important that we express the decision. And I often refer to a video I watched many years ago now, where they have a very good conversation between a doctor and a patient. And at the end of the consultation, the physician says, okay, but now we agree on what we are going to do. And the patient nods and says, but I, as an observer, did not understand if the patient now was going to be referred to operation or not. And then I don't think the patient understood either. So that is why it's important that we are explicit, that we arrive on a decision based on the patient's preferences and medical assessment. And also, of course, it is a decision to postpone the decision. Because these 5 steps could be conducted during one consultation that could only take 5 minutes. But of course, sometimes it can go over several meetings with the patient, right? So that is important to remember. And sometimes we have to postpone the decision, and then we meet again, and we do repeat some of those steps also. Okay, now we're going to see the dentist make a decision.
분께서 아까 이게 제가 설명을 드린 내용 가지고 이제는 결정을 하셔야 되거든요. 아까도 말씀드렸지만 이거는 정답이 있지는 않다고 말씀드렸잖아요. 치아를 살리는 것 그리고 치아를 빼는 것하고는 사실은 치아를 살렸을 때는 분명히 불확실성이 있었으니까, 그리고 환자분이 지금 상황이 외국으로 가야 되는 특수한 상황이 있으니까 거기에 맞춰서 저희가 좀 설명을 드렸어요. 혹시 저 질문이 혹시 있으신가요?
아니요.
네, 제가 알려드린 거는 전부
네.
질문이 없으신 것 같은데 이해하셨다고 생각을 들면 여기에 대해서 이제 환자분께서 뭔가 또 어떤 의사결정을 하신 게 있을까요?
지금 데이터 보니까 교수님 말씀 들어보니까 발치 저 원래 처음에 이거를 어떻게든 살리고 싶었는데 지금 상황도 그렇고 그냥
Did they make a decision? Okay, good. Then I will stop it there. Okay. I just clipped those videos this morning. So, but they made a decision, right? Yes, good. Okay, and then they already went to the next step, maybe a little bit, to the follow-up. In the follow-up, in this last step, we agree on further plans. So what are we going to do? Are we going to start a chemotherapy treatment next week? What is the regime going to look like? Or are you going to see your GP to get some medications? So we agree on the further plan, what will happen, or the nurse will follow you up. And then we also have to agree on how to evaluate the decision again. So if you amputate a leg, there's no way back. But if you start on medication for depression or on chemotherapy, you might experience such severe side effects that we have to agree on when and what criteria we are expressing for when we should evaluate the decision again. Based on maybe the patient's preferences will change over time also. So this is important. So then we are going back to the dentist. And really, also, since I don't understand, I hope this will be right now.
발치랑 임플란트 해본 적이 없는데 혹시 아픈지 그것도 궁금해요.
지금 현재 상태에서는 발치가 아주 어려운 상황이 아니에요. 왜냐하면 다 파괴되어 있기 때문에. 다만 지금 염증이 한번 있었던 자리라 지금은 염증이 좀 줄어 있어서 발치하고 나서 그렇게 통증이 심할 것 같지는 않습니다. 네. 오늘 저희가 그러면 일단 오늘 만약에 진행하시길 원하면 오늘 마취하고 진행하고요. 아니면 약속을 잡아서 따로 진행을 하겠습니다. 네. 혹시 저희가 이제 오늘은 이제 약속을 혹시 잡게 되면 오늘 발치를 안 하시고 약속을 잡게 되면 한번 이 자료를 다시 보시고 또 결정을 또 바꾸실 마음이 있으면 다시 얘기를 하면 되니까요. 네, 편하게 말씀 주십시오. 네. 감사합니다. 잠깐 계세요. 네.
Okay, so I think that he says that if you want to proceed, we can do that, or we can make an arrangement to do it later, and you can review this material, and yeah, please let me know what you decide and what you go further, right? Okay. Okay, so now we are through these 6 steps of shared decision making. So does anyone want to comment here? Do you think this is recognizable for you? Some of you are nodding. Does somebody have some questions regarding these steps? And in your folder, you have a card that looks like this. And this is a handout pocket card we use within our trainings. And here the steps are explained. So it's of course not the meaning that the clinician should read all the bullet points when you are within a consultation, but just having the card on your desk might help you remember to go through the different steps. So a lot of our medical students and doctors in specialization and also all clinicians are receiving this kind of card. And we actually, are there some nurses here? Please put up your hand. Nurses or other healthcare professionals? Very good. So we have a special card also for nurses here. I don't think, maybe you have it in your file. I'm probably suddenly not sure. But I have several so you can get them later. So here we have just made some adjustments and I'm going to talk to you about them a little later. Okay. So now we take a small break again, and then we will have an observer exercise where we will watch a video together and assess the patient involvement. Okay, so a small break. Now, so to give you some meta communication, in our trainings in Norway, we use a lot observer skills. So we use a lot of real videos of clinical encounters, show them as good example or suboptimal examples. And now we are going to watch a video together. It's a Norwegian video with the English subtitles. And this is based on a real consultation. So a doctor in specialization, she said yes to that we could make a video of a consultation. And then we played it once again with actors so that we could show it to everyone because it was a real consultation. So because of the ethics, we cannot show it everywhere, but this one we can show. So now you are going, this consultation is about choosing treatment for prostate cancer. I know there's some working in oncology here. It's a male, 65 years old. He has previously been operated for localized prostate cancer. Now the PSA has risen, and he has small bone metastasis. Yes. So the problem is now the choice of further treatment, and the options is hormone therapy or wait and see. So now you can go in your file, in your maps, and then you could take this out, the map in observer sheet. And so you can see that on this sheet there are quality criteria of these six steps. And now you will assess if you see these steps happening in the video. So do you see this type of behavior is happening? So, and remember that the 6 steps are chronological. They should happen in this way. And then in the end, the tailoring the communication approach and checking mutual understanding, that could happen during the whole consultation. Okay? Is it clear? Very good. So then we watch a video, and then you will have some time to do the waiting, and then we will take a discussion. Ich bin noch nicht so weit. Let me see. Okay, so the duration of the video is 7 minutes. And now I will start.
Da har jeg noen minutter før min neste pasient her. Skal vi se. Knut Sørensen, født 55. Han operert for lokal prostatakreft. PSA har steget, og vi har funnet multiple små skjelettmetastaser. Ja. I dag må vi da se på hva vi skal velge videre behandling, og vi har 2 alternativer som tilgjengelige. Hormonbehandling eller vente og se. Hei Knut, og takk for sist. Du var her sist for cirka en måneds tid siden. Da var du her sammen med din kone, og du her alene i dag. Vil du si litt om hvordan du har hatt det siden sist?
Nei, jeg synes det har gått greit, men jeg jo litt spent da, på hvordan det ligger an.
Det forstår jeg. Jeg skal fortelle deg om prøveresultatene, og så skal vi planlegge den videre behandlingen. Høres det greit ut, eller det noe annet du ønsker å avklare før vi setter i gang?
Nei, det høres greit ut.
Målet med den utredningen som du har vært gjennom siden sist, var å finne ut om prostatakreften har spredt seg i kroppen din. PSA-verdien lå forrige gang på 8,4. Der ser vi en liten stigning fra de blodprøvene vi har tatt i dag. Den ligger nå på 9,3. De andre prøvene viser helt fine blodverdier. Alle organene, nyrene og leveren virker som de skal. Og det jo et bra utgangspunkt for videre behandling da.
Ja, akkurat.
Så det CT-bildene dine. Der ser vi på de indre strukturene, altså bløtvevet og alle organene. Der det ikke vist noe tegn til spredning.
Ja.
Så det skjelettet. Vi tok jo en skjelettscintigrafi i tillegg, og bildene der viser tegn til noe spredning, noe i ryggen og i lårbeinet på den ene siden.
Det på høyre eller venstre side?
Det skal jeg sjekke. Det på høyre side. Du har jo hatt litt skjelettsmerter en stund, var ikke det akkurat der på høyre side?
Jo, her på høyre side.
Vi ser nå en langsom PSA-stigning, og vi vet nå at kreften har spredd seg. En behandling nå vil gis for å kunne holde sykdommen i sjakk mest mulig fremover. Men så det slik at det både fordeler og ulemper ved det. Hva syns du selv?
Nei, jeg legger det i deres hender, jeg.
Ja, det absolutt en mulighet å ikke gjøre noe, altså å fortsette å observere uten å gi deg behandling. Det fortsatt mulig. PSA-verdien din ikke så veldig høy, og det ikke mye spredning i skjelettet. Et annet alternativ hormonbehandling. Det det mest nærliggende, men det jo noen bivirkninger forbundet med det.
De får jeg leve med.
Ja, det virker som du kan takle det meste, og det jo en egenskap som kan være nyttig nå. Prostatakreft jo hormonfølsom, og behandlingen virker ved at effekten av hormonene blokkeres. Det det vi kaller kastrasjonsbehandling, rett og slett. Jeg snakket med mannen min i går, han også lege, og han sa, hvorfor kaller dere det kastrasjonsbehandling? Det høres forferdelig ut. Og det jo ikke det at vi fjerner testiklene, men det en medikamentell kastrasjon, og det vil jo gå på manndommen løs da. Du vil miste seksuallyst.
Ja, men den borte.
Den allerede borte, ja. Ja, for du hadde jo problemer allerede etter operasjonen. Du har ikke hatt ereksjon siden da?
Nei, det borte alt sammen.
Ja, da hadde ikke det vært et tap ved denne behandlingen. Men det flere. Du kan få litt humørsvingninger. Det vil si du kan føle deg litt nedstemt, ha vanskelig for å komme i gang. Stoffskiftet endrer seg. Det gjør at man lettere legger på seg. Så det litt sånn generelt muskelsvinn. Og på lang sikt, altså testosteron virker sånn at den stimulerer benproduksjonen, så man har litt økt risiko for osteoporose, altså benskjørhet på godt norsk. Så da det viktig å holde seg i fysisk aktivitet, gå turer og belaste skjelettet.
Ja, jeg får ta kontakt med han Ingebrigtsen da.
Da hadde du virkelig fått kjørt deg. Det kanskje litt i overkant. Altså man trenger ikke ekstremtrening, men hvis du får til en halvtimes gange en gang i løpet av dagen, hver dag, så det kjempefint.
Ja, det blir som regel det hver dag, uansett.
Så bra. Du jo ellers i god form da.
Det ligger ikke på latsiden.
Ja, det et godt utgangspunkt. Så hvis jeg forstår deg riktig, så ønsker du å starte behandling.
Yes, det vil jeg.
Da vil vi forvente at PSA vil synke betraktelig. Den vil gå veldig ned, for da slutter PSA å bli sluppet ut. Og hvor lenge denne behandlingen vil ha effekt på deg, det helt umulig å vite. Den kan vare i flere år. Den kan vare i måneder. Og derfor så det viktig å følge PSA mens du bruker denne medisinen. Og hvis vi ser at PSA holder seg lav over flere måneder, så kan fastlegen følge deg. Hvis vi ser at den begynner å stige igjen, så kan du bli henvist tilbake til oss, og da det flere andre linjer med behandlinger vi kan følge. Bare sånn at du vet at ikke dette den eneste behandlingen vi har å tilby.
Det bra.
Okay, so now I will give you some minutes so you can look at the sheet and note your observations from this video. Maybe we don't have to take from the total beginning because that's not necessary, I think, but we can start maybe here it's good. Okay. Da har jeg noen minutter før utgangspunkt for videre behandling da.
Ja, akkurat.
Så det CT-bildene dine. Der ser vi på de indre strukturene, altså bløtvevet og alle organene. Der det ikke vist noe tegn til spredning.
Ja.
Så det skjelettet. Vi tok jo en skjelettscintigrafi i tillegg, og bildene der viser tegn til noe spredning, noe i ryggen og i lårbeinet på den ene siden.
Det på høyre eller venstre side?
Det skal jeg sjekke. Det på høyre side. Du har jo hatt litt skjelettsmerter en stund. Var ikke det akkurat der på høyre side?
Jo, her på høyre side.
Vi ser nå en langsom PSA-stigning, og vi vet nå at kreften har spredd seg. En behandling nå vil gis for å kunne holde sykdommen i sjakk mest mulig fremover. Men så det slik at det både fordeler og ulemper ved det. Hva syns du selv?
Nei, jeg legger det i deres hender, jeg.
Ja, det absolutt en mulighet å ikke gjøre noe, altså å fortsette å observere uten å gi deg behandling. Det fortsatt mulig. PSA-verdien din ikke så veldig høy, og det ikke mye spredning i skjelettet. Et annet alternativ hormonbehandling. Det det mest nærliggende, men det jo noen bivirkninger forbundet med det.
De får jeg leve med.
Ja, det virker som du kan takle det meste, og det jo en egenskap som kan være nyttig nå. Prostatakreft jo hormonfølsom, og behandlingen virker ved at effekten av hormonene blokkeres. Det det vi kaller kastrasjonsbehandling, rett og slett. Jeg snakket med mannen min i går, han også lege, og han sa, hvorfor kaller dere det kastrasjonsbehandling? Det høres forferdelig ut. Og det jo ikke det at vi fjerner testiklene, men det en medikamentell kastrasjon, og det vil jo gå på manndommen løs da. Du vil miste seksuallyst.
Ja, men den borte.
Den allerede borte, ja. Ja, for du hadde jo problemer allerede etter operasjonen. Du har ikke hatt ereksjon siden da?
Nei, det borte alt sammen.
Ja, da hadde ikke det vært et tap ved denne behandlingen. Men det flere. Du kan få litt humørsvingninger. Det vil si du kan føle deg litt nedstemt, ha vanskelig for å komme i gang. Stoffskiftet endrer seg. Det gjør at man lettere legger på seg. Så det litt sånn generelt muskelsvinn, og på lang sikt, altså testosteron virker sånn at den stimulerer benproduksjonen, så man har litt økt risiko for osteoporose, altså benskjørhet på godt norsk. Så da det viktig å holde seg i fysisk aktivitet, gå turer og belaste skjelettet.
Ja, jeg får ta kontakt med han Ingebrigtsen da.
Da hadde du virkelig fått kjørt deg. Det kanskje litt i overkant. Altså man trenger ikke ekstremtrening, men hvis du får til en halvtimes gange en gang i løpet av dagen, hver dag, så det kjempefint.
Ja, det blir som regel det hver dag, uansett.
Så bra. Du jo ellers i god form da.
Det ligger ikke på latsiden.
Ja, det et godt utgangspunkt. Så hvis jeg forstår deg riktig, så ønsker du å starte behandling.
Yes, det vil jeg.
Da vil vi forvente at PSA vil synke betraktelig. Den vil gå veldig ned, for da slutter PSA å bli sluppet ut. Og hvor lenge denne behandlingen vil ha effekt på deg, det helt umulig å vite. Den kan vare i flere år. Den kan vare i noen måneder. Og derfor så det viktig å følge PSA mens du bruker denne medisinen. Og hvis vi ser at PSA holder seg lav over flere måneder, så kan fastlegen følge deg. Hvis vi ser at den begynner å stige igjen, så kan du bli henvist tilbake til oss, og da det flere andre linjer med behandlinger vi kan følge. Bare sånn at du vet at ikke dette den eneste behandlingen vi har å tilby.
Det bra.
Okay. So now you can have a little bit more discussions and then we'll go through it together. Okay. So you are having very good discussions and it's very interesting going and listening to your discussions.
First of all, I really want to thank you that you really did it. So often that people sit there and they make a few crosses, but you're really engaged. You really discussed this thing. That's great. This is how it should work. And then I wanted to encourage you to say something before we come to the codes and go through all this different criteria, that you can say something, comment something on the video and on the condition or on the what you observed in general before we go in detail.
I would like to say something before we do that, and that is that we discussed on this table that this is an actor. He's a patient representative. He's also an actor, and she is also an actor, right? But it's based on a real encounter from a doctor in specialization, a real patient.
Word by word.
Word by word, they're saying the exact same things. And then I agree, we will take a little round, and I would like you to say again, you can do it in Korean. You can do it in Korean. Tell me what you thought about the patient here.
Okay.
You can do it in Korean.
Yeah. It's really hard to, yeah. So, 한국말로 하면 굉장히 좋은 비디오인데 저는 이제 환자 입장에서 많이 보는데요. 일단 처음에 제일 시작할 때 problem defining 할 때 그러니까 지금 상태가 굉장히 심각한 우리가 뭐 얘기하려고 할 그 소스가 되는 게 암이고 이제 수치가 어떻게 나왔다고 하는 리뷰를 쫙 하는데 여기에 대한 환자 반응이 있을 것 같은데 환자가 프로바이더가 설명할 때까지 계속 기다리고 있잖아요. 그리고 환자가 한 번도 감정 상태가 변하지 않고 굉장히 이렇게 일정하게 가서 저게 실제 상황에서 가능한가? 그리고 대부분의 환자는 이제 좋은 결과를 치료를 받고 왔으니까 좋은 결과를 기대하는데 저기에서 이미 스탑을 할 것 같아요. 실제 저는 그런 상황들을 많이 봤었고 근데 이제 계속 진행을 하는 저 템포가 너무 빠르지 않나 이런 생각을 했고 그 다음에 환자가 어쨌든 그러면서 이미 이제 옵션에 대해서 얘기를 하는데 주어진 거에서 내가 뭘 할 수 있는지 이미 굉장히 자포자기 상태에서 되게 수동적으로 설명은 굉장히 잘하시는데 근데 환자가 할 수 있는 거에서 내가 이미 그렇고 이런 얘기 하셨고 이제 가장 충격적인 건 프로바이드가 이미 앞서서 당신이 이 치료를 받으면 걱정되는 당신의 이제 라이프에서 남성성이 이제 제한될 거다는 얘기를 프라이빗할 수도 있는 이슈인데 이게 일단 성별도 굉장히 다르고 한국적 상황에서는 성별도 다르고 그런 상황인데 저 이슈를 프로바이더가 먼저 얘기를 하고 이렇게 약간 큐를 하는 멘트도 없이 바로 점핑하는 게 굉장히 물론 자기 남편한테 물어보고 이런 게 나오기는 하지만 저 과정이 저는 되게 계속 쇼킹했습니다. 그래서 저는 이게 환자 입장에서 많이 봤는데 이 비디오에서는 shared라고 하는데 환자가 약간 대상화돼 있는 제가 사약을 공부를 해서 자기 몸에서 일어나고 자기 일인데 그냥 듣기만 하고 이렇게 반응만 하다가 그냥 디시전을 하는 그래서 다 일어나긴 하는데 어디에 액티브가 있나 어디에 인발브가 됐나 어디에 파티시페이션이 있나 이런 게 제가 따라가는데 되게 급했어요. 한국 사람들 빨리빨리 하긴 하지만 여기도 굉장히 빨리빨리 진행이 돼서 조금 인상적이면서 좀 체크를 하고 싶은데 흠잡을 때는 없어요. 6스텝에서 다 체크가 되긴 했는데 환자는 언제 목소리를 내고 언제 자기의 프레퍼런스를 얘기했나 주어진 선택지에서 선택하는 거 외에 저걸 디시전이라고 할 수 있나 이런 생각이 좀 들었습니다.
So this was much more than we had talked about, but it sounded beautiful.
Yeah.
So Hesung translated something to you, right?
I got a fast translation, and first of all, thank you very, very much. This is very, very good observed. I'm so grateful for this kind of comments, and of course, this is also challenging the method. In addition to being a good observation, the one thing is that, of course, actually, the patient, which was an actor, seemed to be more touched and emotionally involved than the real patient in the talk we have on the video. The real patient didn't show any feelings. And I had the same comment, because if I get such a diagnosis, it must be, it's nearly the end. I would be so frustrated. I would have hoped over several years cancer is not coming back, and then I get to know now it's in my bones, and so I would say, yeah, I don't know. I would be completely shocked, and we discussed if the patient maybe has gotten the information little before already, that he was prepared, or that he was emotionally blocked, and then no information comes in, and this is what we know. Look jumpy, and for this, and we didn't code it like this so far, not in the training, but you could go so far, and you did it, to challenge if the whole process with the patient involvement and everything nice that the doctor does, if this is maybe thrown away energy because the patient isn't ready. I agree. It's on the borderline, and I, especially because it's not just because of bad actors. The real one was the same. Mm-hmm. So this we call KO criterion, this knockout, when shared decision making is tried, and someone tries to conduct shared decision making with somebody who is not there, or who is in an irrational emotional state or something. Shared decision making is a rational concept based on the idea to on a rational basis go through a decision. But if a person is very emotionally involved, then it's not possible. And clinicians need to understand that and to read the emotions. This was actually not what we wanted to show, because we are happy about being able to show the other things. But you went even further. Thank you.
So are there any other comments to this video of the consultation? My experience is that Koreans don't jump in the chairs and put up their hands. Yes, come on.
So, ChatGPT가 도와줬습니다. 한번 읽어볼게요. So my question is, the gender relationship between the doctor and patient is also applied to this actors and actress situations. I mean, maybe is it possible that older male patients who might have refrained from expressing their emotion, particularly the feeling of despair and vulnerability associated with the loss of masculinity, the manhood, in front of the physician who is a younger woman? So was it also applied to the real dynamics between male patient and female physician?
Yes, I think that you absolutely have an issue there. This is normal situation. I think the situation is good copied. So it was like this, and I, as a man, I feel embarrassed in the also identifying myself as this man sitting there. It was a terrible situation, and but also I would also I think the physician tried to make it easy for him, but and I don't think it would have been of much worse to have a man there. There wouldn't have been more emotions anyway. But there is especially with this issue and with this topic and these side effects, it's very sensitive. But this shouldn't be the reason. So they shouldn't be able to solve this, regardless of the physician is a woman or the patient is a man or like that.
I see.
So because it's a severe side effect, they're obligated, they have to talk about it. So they do it in the exact same way in the real clinical video, but actually his wife is also in the room. So that could also be a sensitive topic, right? Yeah. So, but he is what we call an introvert, you know, from my side of the country, and the elderly men there are we like laugh a little bit about it, but they are not like used to talk a lot. So so he is not so sharing, but there might be a reason, and the reason you explained, that could be one of the reasons, right? Why he is not talking so much. Very good point. Okay, yes, Jürgen, gibst du Mikrofon?
If we go into the details in the step-by-step, I think the most important thing the missing in this scenario is the missing the key information, the inviting patients to involved in the conversation. While we are discussing, the key message is really missing in this, so that the patients patient cannot be able to express his emotions or his opinion at all. And then the other thing is that the doctor listed out lots of side effects of hormone therapy, but she didn't say that how likely the patients might have those side effects. And the other thing is the deliberation. There is not much time for patients to think through what would happen to them if he made a decision. So there is not much of the deliberation time. So I do not know that they agreed to do that decision making, or it's like more the doctor suggests the hormone therapy is the better option. So I don't know whether they make some agreement for the decision making. And then the arrangement, I think it's partially okay, but it's not clear what is the follow for this patient's treatment. That is what we discussed.
You're doing the whole job for everybody. This was great.
Yeah. Okay, so we can go a little step by step one more time.
Yeah.
So if you think of the first step, was it clear to us that there was a decision to be made, and why? Was that observed? There's some nodding here. Mm-hmm.
So there is a higher PSR, and this is indicating the cancer has come back. So there is something going on, and this means they are in another stage, and the disease is not longer curable. And she says this in a nice way. Mm-hmm. So this item, this indicator, she really solves it in a good way.
And then she asks him, have you thought about this, right? And his answer is, no, I am laying this in your hands. So do Korean patients also do that? Yes. And Norwegian also do that. So, and what could the doctor do when patients say that kind of statement, I lay it in your hands, or could you please, what would you do, or could you give me a recommendation? What could they do? You said it already? No, you said it already. What was missing? Yes, the invitation. The key message, right?
Would you like to give us an example how, for example, this could be done in this situation?
The inviting patients? Yeah. Oh.
I lay it in your hands.
Oh. Yeah, I know that it's very difficult to decide what you want to do, but we first go through what is the benefits and the risk of those options that I suggest, and then we think about your situation. And then if you want to, you can involve your family members in decision-making process.
Very good.
Good.
Did you see her in our training last week? I haven't seen her.
Very good. Okay, so then we are agreeing that there should have been an invitation for the patient, the key message, yes. So the next step is the third one, explaining the options in a structured way.
One minute. Mm-hmm. I would like to add to your suggestion, because it's also okay and very helpful for the patient to understand that you, as a health professional, are not able to find the best solution. And first, when this is recognized, the patient would be motivated to really start thinking on his own. As long as he can think, the doctor knows best, he will not take this invitation, regardless how friendly it is.
Okay. And we will show the same actors do that again a bit later. Okay, so how was the structure in this consultation? Was there any room for improvement? Yes, come on.
One thing I noticed that was when the clinician started listing, I was kind of thinking, oh, is there more? So I'm wondering if the clinician initially said, oh, you have 3 options, or if you have 4 options, or if you have 2 options, because I think there was 2, right? So I'm thinking if the patient's already confused, and if you just start listing, but you don't really state how many there are, I feel like it'd be more helpful if the patient heard, oh, you have 3, and I'm going to list them. That way he can expect and be more focused, I guess. So that's what I was wondering, if in your experience, if it helps to say, oh, there's 3, or, just quantify how many options you do have.
It's a very good point, and it's very clear in our quality criteria that it helps the patient if you make an explicit list. So if you say we have option 1, 2, 3, or you use 3 pens, or you have a brochure that very clearly shows 2 or 3 options, right? So that is very helpful for the patient. And then to also use this structure throughout the process, right? Because we know that patients forget between 60 and 80% of the information we try to provide them. So that's a lot. And if you're a cancer patient and just hear that you have actually the cancer has spread, probably you will be one of those forgetting a lot. So that's why also the structure is very important. So you think she could have been even more structured a little bit, yeah? Yeah, you were waiting. Yeah, okay. Okay, good. So does somebody else want to comment on the structure? Okay. Mr. Novasang?
No.
Yeah, good.
No.
So, if we go into the content of the information provided, you said something. Can I give the mic to you? Because you said there was something missing.
I was not aware of those issues in the first place, but after I listened to your lectures, I think the doctors could improve this communication better with presenting some numbers or some graphics. Even they discuss about the location of the bone metastasis, but she didn't show any pictures. So I thought maybe she could improve better by giving some numbers about their potential risks. Then I think the communication would go further. Yeah.
You also said that it wasn't balanced. More information about the one option.
Yeah. I think it's in the first place, it was not even option talk was clear because the other option, not doing anything, was not explored enough.
So that was a very good observation. So I wouldn't give it a full observed here, because she didn't talk much about wait and see, right? So very good observation. Okay, where did Jürgen disappear? He disappeared. Okay, good. Then, so you also talked about the three C, that there were no numbers presented. So she could have presented numbers both about the prognosis, if the patient wanted that, and also about the side effects, how likely it is to happen, and so on. Yeah, that would have been more optimal. Okay, so how about the deliberation? So did we get a sense of what is important to this patient? Does somebody want to say something here? Somebody was shaking their heads. You say no?
Yes, doctors didn't ask what what is most important to the patient. So she didn't ask anything about the preference and values, anything like that.
So she tries a little bit, right? She makes some attempts to get some information, but it's not so easy. So I agree that it could have been better. We don't sit here with a full picture of what is important for the patient. Yeah. You want to add something?
Yeah, I think this is caused by the same thing we mentioned earlier. The patient hasn't come into his role. Still thinking this is something he hasn't something to say about. So then, even if she would have asked, are there other things important for you we need to consider, he wouldn't have answered. I'm sure about that. And this is because he hasn't understood that it's about him. And this is something to solve very early and very rigorously, actually. He's just accepting with his whole body gesture, everything he says. He's just pleasing her and accepting everything. Castration, no problem. And but as I said, I don't think it could be solved there. It would be to do it earlier.
Okay, what, yes?
In the clinical situation, it's very hard to get an answer from the patient regarding what matters the most part, because in clinical situation, patients do not expect the physicians or nurses ask those kind of things. When we recently collaborate the questionnaire, we did cognitive interview asking about their comprehension regarding the items. But patients do not get what marriage most means in this context because they never have experience asking those things. So in this situation, what kind of things we can do to get the answer regarding the what matters most to them? Is there some strategy you can suggest?
As I said before, I think the information, I know, Dr. Hahn did also comment on it in the break. It's not usual in Korea to spend so much time for a consultation. So the patient might be right in his expectation that there's no room for such. But let us assume there are exceptions, or you change the system, or whatever. Then I think what would help is to say, I don't know what is the best for you. I can explain many things to you. I have the information about risk and harms and things. I can tell you that. But this doesn't tell us what is the best for you. Therefore, I cannot do it for you. So if you don't do it, we will not find out so rigorously. I think this is the best way to do it, because then the patient suddenly recognizes there's something else and compared to what he expected.
And also, so to ask questions, of course, is one method, and also to pick up small, it's not called hints, what's it called in, like small hints during the conversation. Cues, small cues during the conversation. Like when we talk to patient, we pick up small cues, right? What their preferences are, what's important for them. Is the family important? So picking up that during the consultation, and then when you go to this stage, you summarize them. So based on what we have talked about today, it looks like this is important to you. Being with a family is the most important to you. You don't want to stay in the hospital for 3 weeks and so on. So you try to summarize them, and then you ask, is that right? Did I understand you? So that's also one method you could use. Okay, so to the decision, was it clear?
You know, in this item, in this indicator, we do not code if the decision was right or wrong. If you think like we do in this shared decision-making concept, they are not right or wrong decisions. So it's about, was the decision clearly expressed? And did we get the feeling that both of them agreed and thought about the same thing?
So I looked at one sheet here and it said observed. Yes, because we heard the clinician say, so if I understand you right, you would like to start the treatment. And then the patient says, yes.
And very pronounced, very, yeah, I think this was the moment with the most engagement. Yes. three yes.
So if it was an informed decision, of course, we could discuss further, but we're not going to do this because in this indicator, we're just looking and observing if it was clear that a decision was made. In this case, I think it was absolutely observed. So then I want to ask you a question.
Yeah.
What happened after they made the decision? The patient said yes. And then she said, and then I'm going to... Anybody? Not the ones who already know it. So did you hear anything? What the patient said? No, the doctor said? Then I'm going to take you through how this works. And then she said, if the treatment is going to last for 3 months, I don't know that. Maybe it's going to last 6 months. I cannot tell you that. So what is the problem with that?
I mean, it's good. It's good that she tells.
Mm-hmm. Does anybody dare to say something here? No? It was too late, right? It was too late because they had already made a decision. So the patient would, this patient would not have said, what did you say? That this treatment would only last for 3 months? Then I'm not so sure I'm going to take it. He would never have done that, right? So that is why this kind of information about how long a treatment has effect should come, of course, within step 3. When we present the options, the pros and the cons, and the effects of the different options. So it was too late. And when this doctor in specialization watched her own video, after we recorded it and then she watched her own video, that was the first thing she said to me about it. Oh my God, how could I do this? This was, of course, after the decision. So these kind of things we are talking about when we talk about that small structural changes within the decision-making process can have major effects, right? So if you take this in the right place, then the patient can make an informed decision. So sometimes it's only about how we structure the conversation and the information. Okay, and then the plan ahead. We cut the video a little bit, so it was actually very good. She explained very thoroughly for many minutes that now this is going to happen. You're going to visit your GP, and then we have an appointment in 6 weeks, and so on and so on. So she did that in a good way.
Yes.
And the communication approach, that's 7 on this list. And that is about, when I told you earlier, it's about, did she make an effort to change her communication based on or discuss the communication approach with the patient?
And then you must think about everything, maybe the setting, who is there, the moment, the time point, the way they sit and talk, the way they exchange information, everything. It could be everything, but just that it happens that the one responsible for this talk, the health professional, is challenging this. Is this the right way? Is this okay for you like this? We sitting here, your wife at home, like that? or should she be here?
I have a good example because of the comment you gave. So if she could have said, so this treatment is going to affect your manhood. Is it okay to talk to me about this? Or do you prefer to talk to a nurse or a male doctor? Or this could be this kind of type communication approach change we are looking for, to make the communication approach a subject. So you don't understand if I give you verbal pronunciations of, so should I give you some numbers? Should I draw something for you? But she didn't do anything here.
No, and this is usual. Clinicians have their routines. They have good experience what is working, and they try to do more of that what they feel comfortable with. And this is easy to understand. But yeah, good adjustment for the patient would mean to check if this is right. Of course, this is more what a psychotherapist would do. This is the main job of a psychotherapist. It's not so usual to think this, but actually it's what's needed to facilitate informed choices. And then also to be ready to say, okay, if it's like this, we have other videos, for example, from a study where physician nurses have prepared women with kind of breast cancer to the decision making about treatment, and then these patients had a last talk with the doctor where the decision was made, and there we could observe on the video, like you did, that they were not ready. Some of them were just asking for mastectomy. Also, this was seemed quite irrational the way they did it, because there were other options. Even watch and see would have been justifiable. So then we understood these patients are, and there were a few in this study. These patients, they were not ready to make a decision choice. So they are in this emotional state of shock and anxiety. So what I wanted to say to finish my first sentence, then the health professional must be ready to really see the consequence and stop the talk. Say, okay, but we meet next week, also not now. And what else can I do for you to come further with this? Okay. The decision we postpone, and we are not thinking about that today. This one. Yeah, realizing that it's not useful. Do you want to open it?
Should I open it or not?
Yeah. And then we have two other indicators, and they're about the understanding. The first you will think about is, of course, did the patient understand all this information? And this you do not check by asking, did you understand? Of course, everybody says yes. How do you think this was solved in this talk? Do you have any? And now I'm thinking about what happened before the decision, because then the show is over when the decision is made.
Okay.
Do you have any observations of efforts that the two made to assure the understanding of the patient? Yeah, she would, but she didn't. She didn't actually. So, did anybody of you observe something there? You did?
At the end of their conversation, I think the patient was saying, oh, I'm going to exercise, and he felt good about walking. So I think there was somewhat of an understanding. But at that point, his personality kind of changed, and he became a little more excited. So that was confusing. But overall, maybe somewhat of an understanding. Yeah.
As observers, we can never be sure, and it's not up to us to code the understanding of the patient. But what we want to see is if they try to check the understanding. But there was not. But sometimes it's when the patient himself would, like you suggested later, after the decision was made, he was a little more extroverted, and by telling something, also implicitly telling what he has understood. This is also a way to secure understanding, but or to check it. But there was not a lot. And what is about the physician's understanding of the patient's point of view? Did you observe something there? Efforts made to secure that the doctor understands.
She asked some questions, right? Try to understand.
Yeah, especially when it was about the erection and things, she was quite concrete. So she did a good job, and she asked if this would be a big problem, and like that she tried to understand how much worse is in that to him.
So overall, when I met with this doctor, we gave her feedback based on an analysis like you did now. And the two main points in this consultation is that she didn't express the key message. And so that could have been better. And the other thing is that how she could have improved the explanation of the two options, the benefits and harms, how long it would have affect the treatments and so on. So these are the two learning points she got home with her after the training. So and it was it's always a very nice experience to go through videos like this. You learn so much. I also learn something new every time I see a new video about communication. So after we did this with her, we as I said, we used actors to do it again. And then we had the chance, because we used actors, and a lot of our trainers wanted to see a improved, like a good shared decision-making conversation. So that was when we could, by using actors, we could improve some areas, some elements in the consultation. So now I'm going to show you an improved version of this consultation, okay? So I will start there where he says, I'm laying this in your hands, how she could have answered with the key message. Can you change? Okay, now it's wrong. Okay, we have to switch.
Og ulempe ved det. Hva syns du selv?
Nei, jeg legger det i deres hender.
And if you don't see the text, just stand up, really. Okay?
Jeg setter pris på tilliten din, og så forstår jeg også at det er et vanskelig valg å ta, spesielt siden du ikke har fått vite all informasjonen om fordelene og ulempene ved behandlingsalternativene. Men det finnes ikke ett riktig valg her. Valget har...
To the start where she says, not the total first start?
Yeah, that would be better.
The first?
I mean, not
Yeah, okay, good.
At kreften har spredd seg. En behandling nå vil gis for å kunne holde sykdommen i sjakk mest mulig fremover. Men så er det slik at det både er fordeler og ulemper ved det. Hva syns du selv?
Nei, jeg legger det i deres hender.
Jeg setter pris på tilliten din, Og så forstår jeg også at det er et vanskelig valg å ta, spesielt siden du ikke har fått vite all informasjonen om fordelene og ulempene ved behandlingsalternativene. Men det finnes ikke ett riktig valg her. Valget handler om hva som er best for ditt liv, og det vet du mest om. Vi leger kan heller ikke si om hvordan kreften eventuelt vil utvikle seg i fremtiden. Jeg kommer til å fortelle deg om hvilke alternativ som finnes, og så spør jeg deg.
Ja, så det finnes alternativer?
Ja, det er absolutt en mulighet å ikke gjøre noe, altså å fortsette å observere uten å gi deg behandling. Det er fortsatt mulig. PSA-verdien din er ikke så veldig høy, og det er ikke mye spredning i skjelettet. Et annet alternativ er hormonbehandling. Det er det mest nærliggende, men det er jo noen bivirkninger forbundet med det.
De får jeg leve med.
Ja, det virker som du kan takle det meste, og det er jo en egenskap som kan være nyttig nå. Prostatakreft er jo hormonfølsom, og behandlingen virker ved at effekten av hormonene blokkeres. Det er det vi kaller kastrasjonsbehandling, rett og slett. Jeg snakket med mannen min i går, han er også lege, og han sa, hvorfor kaller dere det kastrasjonsbehandling? Det høres forferdelig ut. Og det er jo ikke det at vi fjerner testiklene, men det er en medikamentell kastrasjon, og det vil jo gå på manndommen løs da. Du vil miste seksuallyst.
Ja, men den er borte.
Den er allerede borte, ja. Ja, for du hadde jo problemer allerede etter operasjonen. Du har ikke hatt ereksjon siden da?
Nei, det er borte alt sammen.
Ja, da hadde ikke det vært et tap ved denne behandlingen. Men det er flere. Du kan få litt humørsvingninger. Det vil si du kan føle deg litt nedstemt, ha vanskelig for å komme i gang. Stoffskiftet endrer seg. Det gjør at man lettere legger på seg. Så er det litt sånn generelt muskelsvinn. Og på lang sikt, altså testosteron virker sånn at den stimulerer benproduksjonen, så man har litt økt risiko for osteoporose, altså benskjørhet på godt norsk. Så da er det viktig å holde seg i fysisk aktivitet, gå turer og belaste skjelettet.
Ja, jeg får ta kontakt med han Ingebrigtsen da.
Da hadde du virkelig fått kjørt deg. Det er kanskje litt i overkant. Altså man trenger ikke ekstremtrening, men hvis du får til en halvtimes gange en gang i løpet av dagen, hver dag, så er det kjempefint.
Ja, det blir som regel det hver dag, uansett.
Så bra. Du er jo ellers i god form da.
Jeg ligger ikke på latsiden.
Ja, det er et godt utgangspunkt. Det vi forventer av en hormonbehandling nå, det er at PSA vil synke betraktelig, og det er et tegn på at kreftveksten utsettes. Hvor lenge den behandlingen har effekt hos deg, det er det helt umulig å vite. Den kan vare i mange år, den kan vare i et halvt år. Dersom vi ser at PSA begynner å stige igjen, så er det andre behandlinger vi kan prøve. Bare sånn at du vet at dette ikke er det eneste alternativet vi har å tilby. Er det noe du lurer på?
I think I'm going to stop it here. So now you got a sense of how it could be done a little bit better. So we just like screwed on some buttons, and this is not perfect, but it's much better, right? Because the key message is there, and she also talks about the benefits or the potential duration of the effect before they make a decision. Okay, so now time shows, yes, so we have 20 minutes until lunch, right? So I think we're going to do one exercise before that, and now you can, because when I was going around earlier, some of you said that it mentioned several of these barriers, So now I want you to take these barrier cards. They can take just one set on the table. And then you choose, you can go a little bit through them, and then you choose some of the cards you would like to discuss in your group. So then you will first discuss the barrier. Like my patients ask, what would you do as the healthcare professional? And then you discuss it a little bit, and then you turn it around and look at the answer on the other side and read it loud for the group. Does it sound okay? And we will go and have some discussions with you around the tables. So just first look at them and then pick some you would like to discuss.
This exercise is not meant to be reported in the plenum afterwards, so it's just between you.
Yeah.
You can contact us. You don't need to feel that you need to stand up and present the whole thing to all of you. But yeah, maybe you try to convince yourself with help of our cards.
And maybe many of these barriers are relevant here in Korea, and maybe some of them aren't relevant, and you have other barriers. So you could have some discussions about that as well.
Last comment about that: you have the set of cards now, and the idea is with providing you with such a nice set with high-end printout, that you can take them home and that you can use them when you are in other contexts and when you are the one promoting shared decision making.
Okay, so you can start discussing.